Okay, so this slide here, just as usual, says that everyone involved in this project has no financial relationships to disclose. Our usual funding statement, funded by Nebraska Department of Health and Human Services by way of the federal state opioid response grant. Usual process for CME certificate, just do a quick evaluation survey, and then your certificate will pop right up. That survey will be linked in the chat towards the end of the meeting, and also that'll come in an email usually within a couple hours of today's training. And okay, so we do these echoes in bundles of four. So this is the fourth one in this current training. So we're gonna meet up. The Echo team's gonna meet after this training and plan the next series. So just keep an eye out for an announcement on that. I don't have a ton of details on that, but we usually have been going kind of 2 months on. We do four trainings in 2 months, take a month off, and then come back. So we're gonna keep that rhythm going. And that's about all I got. I'm gonna stop sharing my screen here. Sorry about that. Okay, and I'm going to let our Echo team introduce themselves. Let's see who we've got on today. Let's see, Ed, would you like to go first?
Yeah, you bet. Hey, good morning, everybody. Ed Kaiser here, nurse practitioner in Omaha, Nebraska. Again, primarily do remote telemedicine stuff with opiate use disorder, but was just talking to Mary. I did launch online for Kaiser Consulting alcohol treatment, so kaisertreatment.com for just alcohol use disorder. So I'm excited about helping with that. Really excited to be with you guys. Thanks for joining us, and yeah, glad to be here.
Thanks, Ed. Mary. Oh, you're on mute, Mary. Oh, we got a good background. Let's see.
I'm so sorry. I am having so much trouble this morning. Mary Ellis, I'm a nurse practitioner and attorney in the state of Nebraska. I work with this population, and you guys have a great day.
Thanks, Mary. Alex.
Morning, Alex Dwork. I am a family physician who does underserved medicine in Omaha. I have a variety of interests, including infectious disease. And I still remember somebody who had hepatitis and untreated pain and cirrhosis who was in the hospital, and our attending, when we saw her saying, like, slam that morphine in there, nurse, and clearly had an untreated substance use problem. The attending looked us square in the face and said, "That's an intern level problem," and walked away. So I didn't get much training in this. I am very happy to be here with you all and try to do my part to help things be better now than they were when I was a resident.
Thanks, Alex. Todd.
Good morning, Todd Stoll. I'm a psychiatrist.
Thanks, Todd. I don't think John Massey's on with us, at least not yet. So, Stephanie, I will let you introduce yourselves and take it away.
Good morning, everyone. Stephanie Bennington here. Primarily practiced in Rapid City, Chadron area, psychiatrist. And today I'm going to discuss some of the psychosocial challenges that we all encounter when it comes to treating substance use disorder. Give me a minute. Let me pull up this slide. Are you guys able to see it?
Yep, that looks good. Perfect.
Okay, so the purpose of today's information is I want to go through specific examples that we all encounter in daily practice, regardless of what area of what field you're in. Substance use is so prevalent in some capacity. We encounter patients either in clinic, in hospital, whatever setting you're in. And so I want to discuss some things that we all know, and ways to actually integrate that into how we talk to patients and how we can initiate care or collaborate care for patients with substance use disorders, and then talk about specific case examples that when you're presented with it, in how you should kind of go about it and navigating that. So some things that we'll discuss is the psychosocial and culture barriers. A big area that I'm commonly referred patients for is ADHD treatment and history of substance use, specifically a history of methamphetamine use. This is a common one in substance use disorder treatments that all providers are cautious in treating, which rightfully so, given the risk potentially associated with it. Also, we'll just address challenges, epoxy toxicology results in treatment, and what do you do with it? Should it be checked? Should it not be checked? And if it is, and it's positive, what do we do with that positive result? Then we'll discuss the socioeconomic, cultural, spiritual, and systemic barriers, and then emphasize the ethical principle. Or overall, the goal is part of the treatment is not to abandon patients, irrespective of what they tell you or what they come in. If they have a positive urine drug screen, if they end up doing something that goes against the care or the contract that you have, the goal is not to abandon patients.
I think we may have lost Stephanie. Stephanie, are you still with us? Um, let's see. I think she got kicked out. Don't see her. She looks like she disappeared. Give me a minute and I will try to locate Dr. Bennington. Okay, it looks like she's coming back in here.
I apologize,
Hey.
everybody. My computer decided to try to force restart for some updates. So I
No
apologize. I'm
problem.
back on.
No worries.
Okay. Can you see it okay?
Yep, looks good.
Pick right back up where I was left off. Housing stability is a big issue with a lot of individuals with substance use disorder, homelessness. Not having safe housing can make it quite difficult for patients to store medication safely or to maintain consistent appointments. And this is important, and I mention it here specifically about the store medication safely aspect, because there's a lot of times in treatment contracts with substance use disorder that if medications are stolen or if they are lost or whatever, that there's a lot of steps that patients have to take, whether it's filing a police report, obtaining that police report, giving it to the provider in order to continue on with treatment. This can be a significant barrier in patients being able to continue treatment, because these are steps that patients may not be able to do. Being able to make a police report, maybe if they don't have a phone, or maybe a long distance to be able to access a police station in order to make that report. So I caution what kind of steps are in place if a patient's medication do go missing or stolen or whatever reason. When housing instability is present, the odds of this happening are quite high. So preparing for this, discussing this in advance, what steps will have to be taken that make it easier for patients to continue accessing care. Food insecurity and unemployment also create chronic stress, can make it difficult for patients even to make their appointments because stress, depression, anxiety, limited access to healthcare. Obviously, transportation barriers will make it difficult. Criminal justice involvement can keep patients trapped in a cycle of slips and crisis care. Criminal justice system in general can make accessing certain medications not possible while they're involved in both the medical and criminal side. But the goal is to recognize all of these factors so that you can address the root causes with patients, and then you can directly connect patients with resources, and not just providing those resources to patients, not giving them kind of a list and kind of expecting them to follow through with setting that up, but actually helping patient get connected with those resources. If they leaving the appointment and having another date set up to maybe see a social worker, or maybe see psychiatry, whatever it is, but giving patients that plan in place before they leave your office. And kind of what I just discussed in the last one, but obviously financial instability is going to make it significantly difficult for patients to access treatment and recovery in general. They don't have income, obviously. They can't afford medications or travel to appointments. So getting them connected to social worker or a community specialist that either help them get access to Medicaid or get access to free bus passes if that's available in your community. But the whole goal is to actually line those services up for patients or line them up with the appropriate individuals to help them get these resources. The whole role of the provider in the patient's treatment plan is to advocate for them, document these barriers, and then connect patients with these available supports. And again, actually giving the patient an appointment date or giving them a phone number, telling them exactly when to call or who they will talk to, kind of giving them the idea of what they will expect makes a significant impact on patients being able to follow through with the care. Cultural and ethnic considerations are extremely important and a lot of times can be overlooked in substance use disorder. Culture will shape how substance use is perceived and whether patients will actually seek treatment. In some cultures, substance use can be viewed as a moral weakness or family shame rather than a medical disorder. So this can prevent them from actually accessing treatment or even asking for help. It prevents them from even disclosing during appointments, or patients may avoid treatment altogether. Minority groups often face disparities in access to treatment programs and culturally competent care at a higher level. Essential to providing culturally sensitive care is important to use things like interpreters when needed to make sure that patients actually understand, using language that patients will be able to fully understand what the treatment is or what you're asking. A lot of times if patients don't understand what you're asking, they'll generally just say yes or no or kind of nod, looking for that, trying to find that answer that they think you want them to say, rather than truly understanding what you're discussing or what the plan is. Having that open dialogue is exceptionally important. And of course, integrating cultural values into the treatment planning, and bringing this up initially in the discussion to see if this is an important aspect in the patient's life. Because if it is, this should be integrated in all aspects of the treatment planning. Religion and spirituality, of course, are powerful influences in many patients' lives. And so if this is an aspect of a patient's life that is important, being able to integrate that into the recovery program is important. Faith-based recovery programs can provide community and resilience, but they can also carry stigma if addiction is viewed as bad or is viewed as a sin. So being able to kind of navigate that with the patient, motivational interviewing can be helpful in having them discuss what their feelings are about this, so that they can continue to align with their faith or their spirit, with their faith, or spirituality, so that they don't feel like they have to live separate lives in order to get substance use treatment. For some patients, these spiritual practices are central to their coping, while others may feel judged or excluded. So being able to discuss that with patients up front can be very helpful in recovery. But ultimately, the goal is to respect patients' spiritual values and incorporating them if it's important in the patient's life. And then some other options would be connecting with chaplains or community leaders if appropriate, and if the patient wants you to do this. Certain populations do experience higher risks of a developing substance use disorder because of the disadvantaged background, which we all know, and we all, I'm sure, have experienced in some way, or have we've had patients come in, and we all know the barriers that patients can face in being able to access treatments. But specifically, individuals in foster care, trauma survivors, migrants, refugees, LGBTQ individuals do face unique barriers that we need to be aware when coming up with a treatment plan for substance use disorder, and asking the questions for substance use disorder, and being able to establish that rapport. They, of course, may have less access to treatment, more exposure to trauma, and then higher vulnerability to stress. So these are things that absolutely have to be addressed concurrently with the substance use treatment. Recognizing these risks, offering trauma-informed care, and advocating for these additional resources is helpful to support the recovery, and is absolutely necessary in order to fully understand what the patient has had to go through, what they're continuing to go through, and why this patient may be using substances in the first place. If you've listened to any of my previous presentations, I'm a big advocate for treating of ADHD appropriately, even in the adult population. A lot of times, patients will kind of go missed if they weren't that unruly kid that was out of their seat, or disrupting the class, interrupting the teacher, talking, having to get their desk moved out in the hallway. If the child liked school and they generally did well, a lot of times ADHD is missed. And then there's the idea that potentially these individuals then outgrow ADHD, and it just goes away when they become an adult. A lot of times they can form appropriate coping skills that make it so they can manage their ADHD symptoms without medications, but ultimately the diagnosis does not go away, and it continues to be present in adulthood. With ADHD, the risk of substance use is higher. There's documented and evidence-based research to support the risks associated with untreated ADHD if they don't develop those appropriate coping skills by adulthood. But a lot of times when patients present to my office or are referred to me, there's that underlying ADHD that was never treated. But a lot of times at this point, the patient has already went to substances, whether it be a stimulant, or whether it be alcohol. It can be anything. A lot of times it's polysubstance because they don't really have any preferred substance of choice. They just kind of like it all. A lot of times that'll happen if patients have never used cocaine or methamphetamine. They'll kind of just try anything to kind of get a different feeling than what they kind of calm their brain in a sense. But ultimately, when patients come to my office and they do have this prevalent history of ADHD, and they either have a history of substance use or actively using, a lot of times there's this concern that if we treat ADHD using our first line treatments, am I potentially going to make their substance use worse, or am I going to make them slip or have a relapse? So that's kind of the dilemma that a lot of providers face, especially in primary care settings. This is a common call that I get on how to navigate treatment options for these type of patients. But ultimately, it comes down to the risk of treatment versus the functional improvement associated with treating ADHD. Diversion potential versus untreated ADHD, worsening relapse risk is what you need to think about. And a lot of times, there's more concern about the diversion potential, and so patients with ADHD can go untreated and end up having worse outcomes as a result of this. This should be viewed as any other medication treatment for any other disease. Risk stratify is what you should really look at when it comes to treating ADHD and substance use. Benefits and risk, same concept. You can consider non-stimulants first, but ultimately stimulant medication is still considered first line. For patients with substance use disorder history, using long-acting forms of the stimulants is recommended. Ultimately, the take-home message here is to not avoid stimulants solely because of their substance use history alone. There's a lot of pieces that come into play here when it comes to their history, and a lot of times for these individuals, had they been treated prior to whatever adversity they end up facing that potentially led to the substance use to occur, had treatment been in place well before that, then potentially patients may never have had to go to substances in the first place. So these are kind of the things that we need to think about when deciding how to treat this. So I'm going to add quite a bit of potential case examples that I feel like are pretty common in primary care settings in general. So I want to be able to kind of go through these cases so that when these patients present to your office or setting, whatever it may be, that we kind of have a plan of how this could be initiated, for how the treatment could be initiated. So common scenarios: a 27-year-old reports past methamphetamine use. ADHD is now impairing his work and school. So we got those two different environments there. And during the evaluation, it was obvious that symptoms had been present since childhood. So let's just assume that the ADHD diagnosis is present, and it's accurate in this case. So initially, there's this concern that this history of methamphetamine use, that this patient may be looking to just get a stimulant. Maybe there's a concern that they like methamphetamine. Maybe they're continuing to use it, and now they want a pharmaceutical option that's legal so they can continue this substance use. This is the most common scenario when I get consulted on patients with ADHD and methamphetamine use. It's this concern that they are looking for a pharmaceutical way to continue their addiction. When this scenario presents to your office, starting with a non-stimulant option is a perfectly good option as a first-line option. Stimulants, again, are still first line for patients with ADHD. They're effective. They work exceptionally well. But given that methamphetamine use, we would need to know a lot more information in order to determine if we should go with the non-stimulant option first or a stimulant. If a patient told me that they had just stopped using a month ago, then that's considered ongoing use. So using a non-stimulant option would be recommended in that case. If this was a couple time uses, maybe 10 years ago, going with a stimulant long-acting option is likely what I would choose in that case. Overall, cautiously trialing stimulant with safeguards. If the patient fails the non-stimulant medication, should be the second choice if they started with the non-stimulant option. Stimulant treatment, again, remains first line, and have that discussion of the risk versus benefits with the patient. some safeguards that you can have in place for when patients follow up, and put in your documentation to kind of discuss that risk versus benefit, is contracts. You can have substance use treatment contracts or stimulant contracts. Basically say, I'm not gonna fill stimulants early. If you run out, then that's, if they get stolen, maybe I'll refill it once, and then after that you kind of have to go without. Another one is pill counts. This is something I generally integrate in all of my treatment options with substance use. Is I generally will always have patients bring in their medications that I'm prescribing, and not necessarily because I don't believe them or I think they're lying or withholding information, but ultimately a lot of times patients are on a lot of treatment, a lot of medications, and then I can see which ones they're taking or which ones they're forgetting, and I can see what barriers that we have. If it's too much, or if they don't know why they're taking it, they're simply not going to take it. And so this kind of gives a better idea. And then with stimulants, if they bring it in and they have 2 left, then we need to have that discussion. Either the dose is too low, or we need to discuss potentially why there's either too many medications, too many pills left over, or not enough. Frequent follow-ups is an option. And I generally do this with all of my patients with substance use disorder and ADHD. Generally I do weekly, sometimes a couple times a week if needed. And then urine drug screen if there's a concern for active use. And this is one that I caution providers on how this is interpreted if the urine drug screen is positive. Because a lot of times I'm not able to get that answer. I think I had a provider say once that, well, I'm not sure, I'll kind of address it if it is positive. We'll kind of navigate that bridge if we cross it. But ultimately, this should be discussed immediately with patient at the beginning of treatment, so they understand that if the urine drug screen is positive, that they will know what the next steps are. And ultimately, it should not be used as a form of punishment, and it should not be used as a way to discharge patients or they're non-compliant with treatment. And I think I discussed this a little bit more later on. Oh, right here. So patients may test positive while on Suboxone, stimulants, whatever it is that they're on. They may test positive for other substances. A lot of times they will. There will be a temptation to stop the treatment prematurely on the patient side, simply to avoid punishment or judgment. This is why that communication piece is so important. If patients know that they may have a positive urine drug screen, but will know that they won't be essentially kicked out of the treatment or kicked out of the practice, that it is able to create a safe space that patients can actually discuss this openly and honestly, and then come up with the next treatment plan of how to address the positive urine drug screen. Ultimately, the best practice here is to continue care unless there's clear harm. If there's no clear harm and patients are using another substance, that's another substance that we need to address in helping patient come off. But ultimately, remaining on Suboxone should be the treatment's choice as long as there is no clear harm. Ultimately, support exploring the triggers, adjust the plan, and intensify monitoring, psychotherapy, and motivational interviewing should be the next steps if a patient does have a positive urine drug screen. Here's an example. This is a patient that actually had, the patient was on buprenorphine, and they ended up coming in and they had a positive cocaine test. We discussed it. There was a consideration for validating the test because the patient was also on, I can't recall, but potentially a false positive reaction. They were on another medication. So we considered validating the test, but ultimately, after with our report and with our discussion, the patient was able to kind of tell me how cocaine ended up, how they ended up using cocaine and what events kind of led to that. And then we ended up discussing a lot of other issues that the patient hadn't felt comfortable yet discussing with me. So it created a great opportunity to kind of strengthen that rapport and to be able to discuss things that did come into play and had a significant part in why the patient was needing substance use treatment in the first place. So again, supportive, not a punishment conversation. Patients they already feel shame about the positive urine drug screen. So choosing words to take away from that is helpful and really what patients need. And then adjusting the frequency level of care in this particular patient, we adjusted the frequency to twice a week for about 3 weeks, and then scaled it back to once a week. And he did very well with this treatment plan. But ultimately, we were able to continue the buprenorphine, and then kind of this, we had our own little treatment plan for the cocaine use. Stigma in medical settings does remain one of the greatest barriers to effective treatment in patients. And this is one thing that patients generally will discuss, one of the first things they want to discuss with me. There's a lot of times if they go into the ER or they go into the inpatient setting because of complicating factors associated with the substance use, they feel a lot of stigma associated with the substance use, and almost like it's their fault for why they're in the hospital. A lot of statements that patients hear are, if you quit drinking, then you wouldn't have to be here. You wouldn't, your liver would be functioning appropriately if you didn't drink every day. The patient already knows this. These are simple statements that can have such a negative impact on patients' view of treatment and a view on themselves. So this is generally a stigma that we usually have to spend the first couple sessions when patients come to see me discussing this, so that they can trust me and we can develop that rapport. Without that rapport and without that trust, I'm not going to really get the full extent of what their substance use history is, how much they're using, and really the confounding factors that may have led to the substance use disorder in the first place. Once that rapport is established, people with substance use disorder are incredibly, incredibly honest. They want to truly tell you how much they're using, what they're using, what kind of goes through their mind. They want to be able to have that open dialogue that, where they can say, this is me, this is everything about me, in a non-judgmental, non-stigma environment. Because a lot of times these patients haven't had that type of environment to this point. So providers can reduce stigma by using less stigmatizing language. This is something that can be so simple but have such a profound impact on how patients view substance use treatment in general. One of the words is substance abuse. This was a common, term that we used years and years ago, which we have since kind of navigated substance use disorder. And the reason for that is abuse is bad. People who abuse others is an abuser. That's not a good person. So tying substance to an abuser already puts a negative connotation, like they're bad and they're in the same category as somebody who may potentially hurt somebody else, an abuser. So getting away from substance abuse language can be very helpful for patients, and to be able to hear that the more neutral language. Or saying dirty urine. Dirty is bad. Nobody wants to be dirty. So associating their actions with something dirty will kind of lead to that shame and guilt as well. And it discourages engagement, and it discourages honesty as well. So providers can reduce the stigma by adopting this neutral clinical language, framing substance use disorder as a chronic illness, and then modeling compassionate care. I'm going to kind of go through some of this a little bit quicker so I can kind of go through the scenarios. Systemic and policy barriers, of course, are difficult to navigate and can be barriers to patients accessing substance use treatment. Obviously, strict prescribing regulations hinder care. The DEA, there was a X waiver with buprenorphine. These are things that just make it more difficult for providers to even provide care to patients with substance use disorder. And it can create this fear among clinicians that this is a harmful medication, or this is This is a medication I should be scared of, so I don't even want to prescribe it because they had an X waiver before and they don't now, but maybe there was a reason it was in place that, and I don't want to hurt any patients. I don't know a lot about it, so I'm just not going to prescribe it. So having these barriers in place creates this unnecessary fear that should not be there, that the DEA imposes on providers. Insurance denials, of course, are a big headache for everybody, and certainly a barrier for medication-assisted treatment. Care is often fragmented across psychiatry, primary care and addiction services. Being able to collaborate all of these together truly helps treatment outcomes. And then acknowledge and documenting these barriers, discuss them with patients, validating these barriers. A lot of times this is the life that they've lived. They know these barriers. They continue to live these barriers every day, but having somebody else actually acknowledge and validate it can be incredibly therapeutic. Incorporating family engagement when possible, and if patients allow for this, is therapeutic, as it gives patients that supportive framework in their life, and being able to depend on somebody during moments of stress so that they don't end up going to relapse or slips, and they can kind of reach out to their support system. Some ethical and clinical principles. I mentioned before, the overall goal should always be to avoid abandoning a patient if they have a slip or if they have a positive urine drug screen, whatever it is. Avoiding punishment and avoiding abandoning the patient as a result of those issues. Continuity of care is a form of harm reduction. So if there's limited time in your practice, you're seeing this patient, they need additional services, but it got a full caseload, you only got 15 minutes with this patient. Setting up a follow-up appointment for continuity of care, or setting up the social worker to see them next week. This is a form of harm reduction. And this is part of the treatment plan, and simple things that we can do to ensure that patients are receiving this substance use treatment. And again, discontinuing care as punishment for use increases risk of overdose and disengagement. Balancing the safety with therapeutic alliance, maintaining clear boundaries, and documenting decisions is incredibly important. Kind of go through some of these. One thing I want to mention on this slide is motivational interviewing. This is a tactic that I generally use for all substance use patients in the beginning of treatment, because it allows the conversation to be not only open, but allows patients to kind of lead that discussion. And when patients are allowed to kind of lead that discussion and how we got to that appointment, and you'll end up learning not only a lot about the patient in general, but you'll learn a lot of the things that patients are scared of or that patients don't know. And this is the part of my treatment plan that is the most helpful. Obviously, my evaluation is incredibly important, but motivational interviewing, what patients say during the motivational interviewing, is able to tell me more about what that patient needs in a treatment plan than anything else. We've kind of already discussed that. Okay. So I have several cases that I will just kind of run through quickly, ones that we've all encountered in whatever practice you have in whatever setting. And then I'll leave time that if anybody wants to ask about any specific case or discuss any other barriers or issues that you have faced, that we can discuss this as well. So scenario one is chronic pain and substance use disorder. Chronic pain obviously has a high prevalence. This patient is on a long-term opioid therapy. Recent urine drug screen returns positive for cocaine. So what do? Do we continue prescribing opioids or stop it and risk withdrawal? Ultimately, the answer should never be abruptly discontinuing the opioid. As we all know, that's not only does it not feel good, but it can be unsafe for a lot of patients with other comorbid conditions. And this can actually push patients to go to illicit substance use, and this obviously would worsen outcomes. This case should be reframed as a dual diagnosis of chronic pain and substance use disorder. And so the best approach should be careful tapering if the opioids are unsafe, or switching to buprenorphine, which would be recommended in this case. And then increased monitoring, and then having that discussion with the patient and what that treatment plan will be. But ultimately, the guiding principle will be to continue that engagement and care rather than abandonment, and having that open discussion and dialogue regarding not only the cocaine use, but also the opioid treatment for chronic pain. And we kind of already discussed this one, but ADHD in young adult with methamphetamine history. In this case, this was also another case that I had. This patient had a methamphetamine use, but was in remission for 2 years. And he was specifically requesting Adderall for ADHD. He had tried it from a friend, and it was the only medication that had worked at that time, which I'm sure a lot of you have heard patients mention medication specifically by name, and we all kind of maybe feel that sense of, oh, they're looking for this medication maybe for a secondary purpose. But a lot of times patients will tell you exactly what they've tried. They know how it felt, whether it helped them, and this is the reason for kind of bringing it up in the evaluation. Ultimately, untreated ADHD will increase the risk of slips and relapses and functional outcomes. So in this case, considering beginning with the non-stimulant medication like tamoxifen or guanfacine is appropriate in this case, or going right to a stimulant, long-acting stimulant, with strict monitoring if there's no other risks or concerns associated with the patient. In this particular patient, he had actually tried Strattera in the past, and it wasn't effective. And I ended up going right to Vyvanse. We didn't try a short acting in this case, went right to Vyvanse. We ended up titrating up to 50 milligrams, and I continued seeing him, and about 1.5 years later, we're still at that 50 milligram mark. So that ended up being the appropriate medication for him. I did a urine drug screen once on him at the 6-month mark, and it was negative. Otherwise, I never checked his urine again. Scenario 3, a positive urine drug screen while on Suboxone. So this is a 40-year-old patient receiving buprenorphine for opioid use disorder, positive for fentanyl. And there was a discussion with this provider on discharging the patient, assuming the treatment has failed, and concern that there was a concern for overdose, having the fentanyl with the buprenorphine. And we had this discussion, and essentially relapses and slips are part of the disorder. So discharging the patient increases the risk of overdose substantially in this case. And of course, it undermines patient trust, which is what we are trying to avoid, especially when it comes to substance use disorder treatment. I ended up having a discussion with the provider in this case, but ultimately we decided that the best practices was to continue the buprenorphine. And of course, unless there is imminent harm, which there was not in this case. This patient had increased visit frequency. We explored psychosocial stressors, and then there was a consideration for higher level care, such as intensive outpatient or residential treatment, which this patient did not want to do. So kind of created this individualized treatment plan on an outpatient setting with their provider. Scenario 4 is pregnancy and substance use disorder. This is another one I'm commonly consulted on how to navigate this because of the pregnancy and the concern and the risk and the potential legal ramifications that a lot of providers are concerned and scared of. This patient was 28-year-old. They came in intermittently using opioids while enrolled in care. And there was a consideration of buprenorphine should be the treatment of choice for this patient in order to avoid using alternative opioids. And Then there was also the option of well, when the patient came to the hospital, they were having premature contractions. There was a consideration that all ovulation should just be stopped. And so we had to have the discussion that this actually increases miscarriage and relapse risk. And this should never be the treatment option unless there's an imminent risk of harm that needs to be considered. But in this case, buprenorphine was the treatment of choice for her. It's considered safe in pregnancy and should be continued. And then, of course, having that supportive, non-judgmental care with coordination between psychiatry, obstetrics, and social work is essential to optimizing maternal and fetal outcomes. Alcohol use, mental health. This patient had hypertension, diabetes, was used alcohol daily, but the patient really didn't think that his alcohol use was considered a problem. So there's the dilemma of how do you confront or let patients know that this is an issue. So confronting denial versus preserving rapport. Avoiding labels and using motivational interviewing is the most helpful in this case, and being able to help patients get to that insight and understanding that the alcohol use is a potential problem. And then normalizing those discussions by framing alcohol as another chronic condition to manage. Medications like naltrexone or camprosate can be offered, while emphasis on reducing that harm. And this may take a couple visits for patients to actually develop that insight, or to actually kind of go through that thought process to say, okay, maybe it is causing issues in my life. Maybe I do need to have this discussion again. But the fact that the discussion was already in place on those initial visits makes it so patients are more likely and more comfortable to be able to open up and have that discussion again. Benzodiazepine dependence is also a common scenario, especially in primary care settings. Common example is a 45-year-old taking clonazepam for many years, escalated his dose. He becomes angry when tapering is suggested. And this is something I commonly see specifically with clonazepam, and a lot of it comes down to there's a lot of stigma associated with benzodiazepine. They face a lot of issues at refilling the prescription at pharmacies. The word choice pharmacists use, or the technicians use, if it's a little bit delayed, there's just a lot of issues that has led to patients kind of developing that angry when the discussion to taper the medication is suggested. So don't take that anger at face value that this is a serious problem. Consider the other factors that have made patients develop that reaction to having the discussion of tapering it. But ultimately, abrupt discontinuation should never be the option, because it increases risk of seizures. A safer path is to transition to a longer-acting benzodiazepine and then slowly taper with close follow-up. Once you've been able to make that switch to the long-acting benzodiazepine and patients feel that it's that they can safely discuss the treatment options and what their concerns are and what they're scared of. Because a lot of times, if they know what it feels like to miss a dose of the medication, and they don't want to feel like that. And so being able to acknowledge and validate those fears can help kind of patients feel more comfortable with that taper plan. Adolescents in primary care. Common scenario, 16-year-olds experimenting with various substances. The parent asks if it's addiction, if this is a concern, if you guys need to do anything right away, or need to get the adolescent into a treatment program. Providers may not know when to intervene because it can be just experimentation, which can be normal. So the discussion should be focused on what their substance use looks like. If they're doing it alone, this is a significant risk factor, versus if they just tried it a couple times with friends, then we need to focus on education and being able to have the discussion of and role playing how to say no if you don't want to use a substance, or if you feel pressured into doing a lot of times adolescents don't know how to have that conversation. They're told to say no, but when it comes to the social settings, there can be embarrassment. So being able to actually have that active discussion and role playing can be very helpful. Culture, religious barriers. This individual, he was a Muslim male with opioid use disorder. He was reluctant to seek treatment due to community stigma, fearing that this problem will be seen as a moral weakness. Providers may struggle to balance cultural sensitivity with effective care. So normalizing the substance use disorder as a medical condition, reassuring confidentiality, and collaborating with faith leaders only with the patient consent is helpful in the treatment planning. And that education piece in language that patients can understand and isn't scary or isn't makes it more of it creates this environment that patients feel they can ask questions, is essentially what patients need in order to kind of move forward with that treatment plan. We kind of went through that one. Substance use disorder treatment ultimately reduces incarceration. And this is even with ADHD as well, but this is across the board. So addiction treatment directly reduces involvement with the criminal justice system. So ultimately, the goal is to kind of avoid punishment modalities in substance use disorder. And the criminal justice system is obviously is punishment in general. There are some criminal justice systems that do have drug courts and have great programs in place that are very, very helpful for patients, but this isn't standard across the board or across states, unfortunately. Criminal justice system still uses a punishment type of method. And the medical system and the criminal system don't really align when it comes to substance use disorder. So ultimately, the goal is to avoid, if we can help patients to avoid going over to the criminal justice system side, is ultimately going to help patients the most in being able to provide that treatment. Medication-assisted treatment lowers arrest and reincarceration rates. Drug courts integrating treatment demonstrate reduced recidivism compared to incarceration alone, and incarceration itself does not treat addiction. So being in a controlled environment without having access to the substances for multiple years in a row is not a treatment. Outside of that structured environment is generally how, and having access to the substance uses is how to determine if the patient's actually is going to relapse or if they are going to remain abstinent. Okay, 5 minutes. I apologize for kind of running through those cases pretty quickly. I'll also have we'll send these slides to you guys so you can kind of refer back to. But in the last 5 minutes, if anybody has any questions or any cases that they want to discuss specifically, please feel free.
Thank you, Stephanie. Yeah, feel free. We've got 5 minutes. Feel free to speak up. We had a comment from Helen just agreeing, saying, yes, the criminal system is not helpful for these patients.
Yes, unfortunately, the criminal justice system kind of does what they want. And there's times I've tried to court system in Wyoming actually tried to give research studies to show, hey, can we do something different? And I got immediately shot down. It wasn't like, oh, thanks for this, we'll look at it. It was straight up no. So that's a difficult one.
Well, while we're waiting here for a couple of minutes, here we got a question from Kathleen. Thank you for a great talk. Would you be willing to share your med contract or agreement?
Oh, for what patient signed?
Yeah, I think that's what she's referring to.
Okay. So I don't actually have one specifically. I'm sure I have a template. I can certainly share that. Absolutely. Generally, this is determined by whatever whatever facility I'm working at, that the nurse usually has them sign it. I don't actually have a formal med contract that I do with patients. This is all kind of communicated verbally, and then I kind of write it out and I give it to the patient. So I kind of make that contract with the patient individually. But I'm sure I have a template in there that I can absolutely share.
Thank you. Thank you. Okay, a question from Rebecca. Thoughts on, I'm probably going to say this wrong, Qelbree versus atomoxetine versus Wellbutrin for patient with recent stimulant disorder and ADHD.
So in a patient with ADHD, so they meet all of the it's present in childhood across. So a patient that truly has a diagnosis of ADHD, I generally recommend only using medications that are approved for ADHD. Wellbutrin can absolutely be helpful and is often used off-label. However, in patients with a substance use disorder history, they are at risk of either going back to the substance use or incarceration. So sticking to medications that are actually approved for ADHD is what I would recommend. And in this case, it would really determine, are they actively using? Was it in the past? Was it a couple times? And that would kind of determine if I would go to atomoxetine, Qelbree, or a stimulant. Either one, Qelbree or atomoxetine, are effective. One is not more than the other. It really just depends on the patient. Qelbree is expensive, so I generally don't go to that first, but tamoxifen is generally what I would reach for first until Qelbree would be a little bit cheaper, or stimulants. Wellbutrin, I would say for patients that have ADHD without a substance use disorder history, although it can be added on as an adjunct therapy.
Great. Well, we're at the end of our hour here. I did drop a link. If you scroll up in the chat, there's a link to grab that survey and get your certificate. That's also going to come out in an email today. Thanks for your time, everybody, and have a great morning. And the Echo team, if you guys are able to jump over to that other link for a quick meeting, we'll just do a real quick one. Thank you.
It'll take me a few minutes to log on, Will.
Okay. Thanks.
Okay, but I'll be on.
Okay.
Have a good day, everyone.